Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, your host for today. Our topic is how to prepare for the primary care first payment model. Mingle Health is your partner in the transition to value-based healthcare, and we help you improve what matters. We help you save time, improve quality scores, and increase earnings. Some housekeeping items before we get started. This webinar will be recorded. The slides and recording will be sent out by email later this week. You can also download the slides from the handout section shortly here from the side panel in the GoToWebinar system. Throughout this presentation, we do encourage you to ask questions using the question box. We've saved plenty of time at the end for our presenter to answer as many questions as we can. Now, let's go ahead and get on to the presentation. Our presenter today is Roxanne Thacker. She's the Director of Clinical Services here at Mingle Health, and she has decades of care management experience and is our expert on this exciting new primary care first payment model. With that, over to you, Roxanne.
Fantastic, thank you. And welcome to my home office. I know we're all adapting to this new normal. So today, to really talk about primary care first, I'm excited to share what things we really need to work on as practices and as professionals to be ready to take on this new program. And some of it is just understanding how value-based care is going to impact what we do. And some of it is understanding what we need to change and what we need to think about. So we're going to talk about that transformation process, what advanced primary care services are, what they look like, and then how to prepare your practice for primary care first. We'll briefly touch on some of the financial implications for 2021, so participation in the program, and not just in year one, but also in successive years. And as we go along, please feel free to throw in questions. I'll try to get to as many of them as I can at the end as well. So CMS for several years has really had a goal to transform how we think about primary care, because primary care is so integral to our healthcare system. We all know that primary care is not funded very well. You're not paid very well, even though that is really the hub and should be the center of where patients are receiving care. So CMS in their looking to innovate and to change knew that they needed to create a simple payment structure, but really needed to allow practitioners to innovate, to do things in different ways. The goals and the measures for primary care needed to be things that were important to the providers and to the patients, important to preventive health, important to their outcomes. And then there should be financial rewards. None of us would go to work if we didn't eventually get a paycheck, because we're all motivated by something, not just feeling good about taking care of patients, you know. And then we all know that the documentation burden is huge for primary care. You get done seeing patients and you've got, 2, 3, 4 hours of paperwork or charting and, prescriptions to be authorized, messages to be followed up on. So really it becomes something that we need to reduce that burden and make sure that it is manageable. How we save money is directly related to reducing ER use and hospitalizations. So patients should be getting that urgent care as much as they can in a primary care office instead of going to the emergency room for management of hypertension or going to the emergency room for strep throat. It's really an inappropriate use of those resources. To address that, we have to help patients understand what it is that where they should be going for appropriate care. They need to be looking at what does the patient trust the provider to provide that kind of care? Is the provider available for that kind of care? In the age of evidence-based medicine, we also need to make sure that we're doing best practices. not just what we felt was really good. Having now been in practice myself for decades, which is a horrifying thing for me to have to say, lots of things have changed in the last 20 years, and we have to keep up. Not with what was current 20 years ago, but what is current now, and that takes a lot of effort. So often we don't know what we don't know. And so making sure that we're looking at data and analytics to understand what our performance really looks like and how to change it. One of my favorite things that Dr. Dan Mingle says is 100% of physicians believe that they are above average. Technically speaking, we know that isn't possible, but we all want to believe we're above average and that we are providing exceptional care. And the only way for us to see that or determine that is through data and analysis. This picture is from CMS's innovation website, and this particularly addresses the different facets of primary care that need to be addressed so that the system can work seamlessly. It is the ideal, most certainly, and some of our circles can be growing, some of them might be shrinking or adjusting. So in our own practices, this might be something a lot more fluid, but it's really important to realize that, you know, access and continuity, that care management, comprehensive coordination, not just clinical coordination, but also in the community. We need to be sure that patients are getting the right kind of experience, that they are satisfied with the care that they're getting. And then really addressing population health. And that really was not something that was extensively discussed, certainly when I was in training, but more and more we're having to focus on populations. Alex Azar is the current HHS secretary, and he has been quoted to say that PCF is going to be building on the experience of previous models, ideas of past administrations. CMMI has really partnered extensively with several organizations to build PCF in a way that really supports primary care. The takeaway from this is these models can serve as an inflection point for value-based transformation of our healthcare system, and American patients and providers will be the first ones to benefit. The transition to value-based care is something we've talked about for a long time, but it hasn't really been funded the way it needed to be to make it something that would go forward and would be successful. So I think primary care first is one of the biggest steps forward we've seen in some time. So the payment methodology particularly changed. The per beneficiary per month amount changes based on your practice's average HCC score. So you can see the differences there from groups 1 to group 4. That second to the last column, that estimated per beneficiary per month value of the flat primary care visit fee, this is based on information for the flat visit fee plus the $18 copay times the number of visits that the patient usually has in 12 months, divided by the 12 months, and that's what that 21 looks like on that first line. When we talk about rates being geographically adjusted, all Medicare payments are geographically adjusted, whether you're in fee-for-service or whether you're in advanced payment model. And that really accounts for differences in cost of living as we go from different areas. So for instance, the payment that might a physician or practice in New York City has is going to be different than the payment in Cheyenne, Wyoming. So some things to think about as far as, you know, how CMS adjusts payment across the country. So the payment methodology again is changing so that patients who have a higher disease burden, practices that are caring for those patients receive a higher payment because they're more complex. They're requiring more attention. They're requiring more refills to be authorized. They're requiring more prior authorizations, more referrals, more overall care. The flat visit fee really takes us from the place of the fee-for-service treadmill, where you're just trying to get as many patients in as you can, to really focusing on what is it this patient needs, what is it that we need to document, what do we need to do. The seriously ill population is another part of PCF. It will not be active until the 1st of April, but the seriously ill population are patients who have fragmented care. They tend to be really expensive patients. They're using a lot of hospital care, a lot of emergency room care. They may not have a consistent PCP or are not using one consistent PCP. So they may have multiple. And it could be a host of reasons. So those seriously ill patients are going to be reimbursed at a much higher level, but they also will require a great deal of effort on the part of the practice. Just like any quality-based program, we've got to measure quality, and CMS has also felt strongly that you should be bonused based on quality. So if you're performing exceptionally well, better than your peers, you should get more money. And so they do that, they calculate that quarterly, and your practice would receive that bonus payment. So what is the timeline? What do we need to be doing this year, getting ready for January? Well, hopefully you've been working throughout the year to maximize your attribution. The easiest way to maximize attribution is by completing annual wellness visits, because that is one of the primary attribution methodologies. Care management is also a part of the attribution methodology, and there are additional methods as well, including the patient selecting the provider from mymedicare.gov. In addition, during this preparation year, hopefully you've been working to expand your care management program. Do you have the right people in place? Do you have the right people doing the right kinds of things? As we get access to the CMS data, you'll need to be able to decode it, find out what's there, look at it, understand what the analysis needs to be. You'll need to understand the analytics for the program, whether that be the practice portal or whether you're looking at your ECQMs and advanced care planning documentation. What things need to change? How does that need to be evaluated? When CMS started releasing all of the documents related to primary care first, there were a lot. You may be feeling overwhelmed with all of the pages of documentation. Certainly that makes a lot of sense. You're going to have to make sure that whoever is your subject matter expert is really well versed, that they have time to really understand and be able to communicate the important things that are in those documents. Private payers will also be participating in primary care first, and so there may be additional, and probably will be additional, private payer contracting tasks that need to be completed in the upcoming months. For program participation, you'll need to continue to provide risk stratified care management. Do you know who those patients are? How are you defining those risk strata? Continuing to use data support tools, BI, and really make a good quality improvement plan. Make sure that you're reviewing your quality measure analytics. Nobody wants to report your quality measures at the end of year one and you don't have any idea what they're even going to look like. That doesn't even make sense. Why would we not look at our success or our opportunities throughout the year so that we can make changes? So making sure that you have a good plan for that. Monitoring that progress is going to be important. And then remember, you have to report that data to CMS in 2022 in Q1. Those are due February 28th of 2022 for your quality gateway measures. And then making sure your staff, your whole team is committed to quality improvement. Quality improvement can be hard because you don't always get success. Sometimes you have to fail, you have to stumble a little bit. And particularly in medicine and in practice, we don't like how that feels. If something doesn't work, it makes me feel uncomfortable. It might make you feel uncomfortable. But learning is a part of this process. So some more about what I think are the best tips and tricks to this is to recognize that you need the right tools. And sometimes what we think might be the right tool isn't the right tool. So this little cartoon made me laugh. We can fix a broken rib with Photoshop. So I thought that was pretty cute. So again, first things first, we've got to make sure attribution is correct throughout the entirety of the program. The initiation of it, all the way through all of your quarters of participation. Attribution follows the information that is listed there. So self-attribution, most recent annual wellness visits, plurality of care. Also, one that is not on this list is billing of the care management codes. So the 99490 and all of the other codes associated with care management. And certainly if you have questions about that, I can address that more. Think about what your payment structure is going to be. The primary care visit fee really is substantially less than you may be used to when you're billing regular office visits or when you're billing home visits. So how are you going to address that disparity? And financially, do you have that worked out of what that's going to look like? Your population-based payment is based on the health of your patient population. So if your HCC average doesn't match what you expect, why is that? What's happening? And then again, that performance-based adjustment is dependent on your performance on total per capita cost and acute hospitalization, depending on your grouping once you've passed through the quality gateway measures. Performing annual wellness visits is something that the practices that we've been supporting so far have been really focused on. And they've really seen not only increased revenue through this difficult COVID period, but they are also connecting with patients and making good care plans, making sure that they're asking the right questions so that patients are following up with those preventive health care things and that they're identifying needs that otherwise they might not have known about. Review your historical AWV completion rate. Have you ever done an AWV? Maybe you've only done 3 in the last year. How are you going to change that? How are you going to, change your workflow to make that happen? Because that really is a great way to connect with patients and start to make those care plans and maximize HCC scores. So who's going to identify eligible patients? Do you know when they're eligible? Are you going to have to call CMS? What is that going to look like? Who's scheduling these patients? Is it the front desk? Is it the MA? Is it the provider? Who's going to take care of that? Completing that risk evaluation associated with the annual wellness visit. Are you asking them about their fall risk? Are you asking them about missed medication and adherence, ADLs? All of those are really important things to address so that you can work with the patient to establish a good care plan. The AWV also allows you to maximize the HCC score. So making sure that you're coding that annual wellness visit with the appropriate and accurate diagnoses that the patient is dealing with through the year. Really important that you do that. And then do you have the right software, the right tools? We've been working on this for a while. We're pretty good at the tools. I think we're pretty good at the tools, and our practices that we're working with also feel like they're seeing some good success. So make sure that you have the right tools. We'd be happy to talk to you. I'm certain that we're not the only ones with tools. I do know that ours are really good, but I also understand that we all do things a little differently. Next is, do our staff understand how this change could potentially affect them? Do our patients understand how us adopting this more comprehensive view of primary care could impact them? Having conversations with patients about when is it appropriate to go to the emergency room? When is it appropriate to call and make an urgent visit? Maybe there's an urgent care that you need to partner with. If maybe you need to adjust your schedule so you've got some openings for more urgent visits. Do patients have ways to get advice and direction without coming into the office? Who's available for those calls? Who's responsible for those calls? And what kind of time turnaround should the patient expect? If you have care managers in your practice, which is going to be critical to your success in primary care first, patients need to know who that care coordinator is, who that care manager is, and what the role of that care manager is. And sometimes that role is a little vague. That's okay. That's okay. But certainly you have a really good handle on which patients are going to need a little more direction, a little more hand-holding. So you have a really good sense of those patients. Some will surprise you. They need less help. Some will surprise you that they need a whole lot more than you anticipated. But certainly getting in the habit of introducing different members of your team is going to help you to be a lot more successful. Some of the most difficult questions in primary care are, first of all, who are the patients? Who are my patients? Who are the attributed people? If they have a need in the community, who do you call? What happens if they don't have transportation to your office? What happens if they have food insecurity issues? Who do you contact? It's time now to build out those community resources. Make sure that your care coordinator has access to that information, that you've reached out to those organizations so that you can really partner with them effectively. Do patients know to call your office if it's more than a medical related issue? Maybe it's something that, for instance, they are having difficulty with transportation, or they have a colonoscopy and they don't have transportation home. They can drive there, but, secondary to the sedation from the colonoscopy, they shouldn't be driving home. Now what's going to happen? Or do they cancel the colonoscopy because they just don't know how to navigate that? Making sure that your practice, if you have multiple providers, the patient knows who their primary care provider is. Is there a backup person? Does the patient understand that that's a backup person and that you're still getting that information as their primary care provider? Is there a method for communicating with caregivers? Particularly in geriatric populations, often you'll have a caregiver, a son, a daughter, a spouse, a niece or a nephew, maybe even just a family friend who might be helping to coordinate and make sure that patient is getting the care that they need. So how are you communicating with that information? Care management is near and dear to my heart. I know that it's near and dear to my heart, and so I tend to be kind of on a soapbox about it. Because I think not only have I provided care management, but I've received care management for my aging parents. So I'm one of those, sandwich generation people right now. And certainly you need to be delivering care management to the right person at the right time with the right intensity. And if any of those are off, it can cause some challenges, certainly. If a patient we're trying to get them oxygen, it probably makes sense to check on them, every day until that oxygen is going. And maybe you call them every day for a couple of days after they have the oxygen there. Did they figure out how to turn it on? Did they figure out, if the cord got kinked, or if the tubing wasn't working, or, did the nasal cannula rub their nose and so they stopped using it? So often we don't know unless we ask really specific questions in that moment, and then we can address those challenges. But unless we're asking the questions in that moment, patients typically won't tell us, or they won't call and ask because they don't want to bug us, right? Maximize your care team. Who should be doing what? What patients need care? Can you risk stratify? Do you know who those patients are? How are you identifying patients? Is there some way in the EMR that you're identifying that they would be good candidates? Is it just, Miss Sally who calls, every Tuesday and Thursday after she goes to Mass? How are you identifying who those patients are? Communicating is really important, not just with the patient, but also internally. If a nurse or an MA or the social worker is on the phone most of the day, make sure that the team understands what they're doing. because that can be really hard for teams if they feel like one team member isn't pulling their weight, or they just don't understand what's happening. It's really important that everybody understands how things are changing and how patients' needs are being addressed. I'm also a strong proponent of practicing at the very top of your license. So whether that be a nurse, a pharmacist, a social worker, um, it doesn't, a medical assistant, it doesn't matter who that professional is. Let's make sure that they're practicing at the top of their game, because providers can't do it alone. You don't have enough hands, you don't have enough hours, you don't have enough of you to spread any further. So recognizing that your team are bright, that they are concerned, that they care, and that they really want to do the right thing, those are really important things that you let your team know that you believe in them and that you're going to help them to be successful. Patients often don't know what your instructions really are. Um, I was at a grocery store recently, standing in line, and this cute little man in front of me was talking about injecting his insulin. As a pharmacist, right, I hear drug names and my ears perk up. But he had his long-acting and his short-acting insulin switched, and so he was injecting them backwards, essentially. Um, of course, then there's this conflict in me of, wait, this is, protected health information, and should I really know this, and should I have been listening? And so, certainly all this internal conflict. But finally, I thought, you know what? I'm just going to tell him to talk to his pharmacist, or to call his doctor's office, because that could be potentially really dangerous. So, making sure that they not only know, but they have it written down somewhere. Really important. Does the patient understand what the plan is? Were they involved with development of their care plan? Sometimes I know we're in a hurry, and certainly when I think about the patients that I've taken care of, those conversations can be longer than I wanted them to be. That doesn't mean that they're not critical to that care. Thinking about when will you make revisions to the care plan, what things might prompt revisions, um, who is going to be responsible for those revisions. Really important to kind of think through and to make some good notes for yourself and for other providers about what that's going to look like. So when we talk about population health, again, this is something that for some of us is very foreign. So who's missing the critical service? Why are they missing the services? Is it an access issue? Is it a comprehension issue? Is it, the ambivalence of not feeling like they need to do something? Does everybody know what they need? Do patients know what they need, why they need it? Are there systemic challenges that make it such that the patient can't do it? So a great example is, again, I keep using colonoscopy. We had a situation where we were referring patients to a particular clinic only to discover that they didn't take a particular insurance. And so all of the patients that had that particular insurance, we had to reach back out to them and direct them somewhere else. Well, that was certainly a systemic issue that we had to address. Who's the one who's going to make it happen? Is that your front desk staff? Is it a referral person on your team? Is it an MA? Is it a nurse? Who's going to make sure that you follow up? Maybe it's their care coordinator or care manager. I'm, again, because I've been in care management for so long, what is your SMART goal? So for those of you not familiar with SMART goals, it has to be specific, it has to be measurable, something that's achievable, reasonable, and then time bound. Certainly, Google SMART goals, you'll find out tons about it, but we often tell our patients to create SMART goals, but we really don't think about that for ourselves and how we should be addressing change. When we're making change plans, how will you know if the plan changes worked? When will you know if they worked? Making plans for when you're going to revisit that information. Again, what happens if it did work? What happens if it didn't work? Thomas Edison said that when he was inventing the light bulb, he didn't fail more than 100 times. He just now knows 100 ways not to make a light bulb. So it's just thinking about something in a different way. Revenue is always going to be important. If you have a revenue cycle management company or a billing company, think through what the billing and coding changes and those repercussions might be. Maybe maybe you need more tools for billing and coding accuracy or specificity. How are you going to improve HCC coding if it needs to be changed or improved? Is your billing company or RCM compensated based on your billings, or how is that compensation addressed? Do you need to adjust that? Another one might be, do you need to adjust provider compensation methodology? Instead of it being based on visits, is it based on patient acuity? Is it based, how are you going to adjust that in this different payment methodology? Again, quality measurement is a big part of what we do here at Mingle. And again, if you can't measure it, you don't know how you're doing. So it's really important to be able to measure those ECQMs, those quality measures that you're getting out of your EMR, and then also your registry measure related to advanced care planning. How are you going to communicate how providers are doing? We tend to be naturally a bit competitive, at least I tend to be a bit competitive. So how are you going to display those results of performance? What is that going to look like? And certainly if you have an underperforming team member, how is that going to be addressed? What are you going to do? If your performance doesn't match what you're expecting, is it a workflow issue? Is it a documentation issue? Are there gaps that the whole care team needs to be involved in? And certainly reach out to your EHR, your quality management vendors. As a quality management vendor, we really are well positioned to help you understand what information is there and what can be done to address it. So again, plan to review your metrics. How are you going to use that data? Data is just a bunch of numbers, a bunch of data points. But what do you do with that information? How do you test those new interventions? Making sure you have the analytics so that it's timely. Really, really important to think through that timely response and what you're seeing. Is the data something that just the providers are going to look like, or should the whole team be looking at performance? How public are you going to make that performance information? Lots of questions for you to think about and certainly make plans for. I know it feels a little overwhelming at times. Look for the right tools. Look for the right people who can support you. And Mingle has been doing quality support for years. This is something that we're good at. So look for the right partners. Make sure that they can help. So what's the financial impact? I've had practices all over the country say, I don't know if this is right for me. I don't know if it's right for our practice. And honestly, we can certainly talk through it. I'd be happy to talk to any of your practices really to think it through. So this just gives you an idea of some of the data points we look at. So fee for service, you can see that column there in the middle. You can see the annual visit revenue. Obviously, there's not a population-based payment in fee for service. And then primary care first. So here again, your visit revenue is going to be significantly lower, but your population-based payment might be significant. So in this particular example, this assumes 1,400 attributed patients. They're being seen 6 times per year on average, and it is a group 4 practice. So that gives you an idea of some financial consequences. So you can see the net PCF advantage is an increase of 144%. So pretty substantial and definitely worth some innovating to get to there. Please recognize too that this does not include any of the bonus adjustment potential. So what do we do? How do we help? Well, the really great thing about Mingle is we meet you where you are. What issues you have, what challenges you have, we're ready to help you with whatever successes you're having or whatever challenges. So please feel free to reach out to talk through some options or some concerns that you have. We're more than happy to help. So again, just in summary, how do you succeed? How do you succeed with primary care first and more broadly with value-based care? You need to understand the program. If you don't understand the program, it's hard to be successful. Hire and train the right staff. Make sure that you're using them in the very best possible ways. Make sure that you have the right tools. No reason to try to, manipulate tools to do something that they're not designed to do. Make sure that the right people are using the right thing. Spend the time with the right patients. That one's kind of self-explanatory. Make sure that the patients who are in the most need get the most attention. And it may not be because of their chronic illness. It may be related to their social determinants of health. It may be other things that are happening for them. Recognize that you have that professional ability to see those patients who are in the most need. Proactively manage patients. So often in medicine, we're reactive instead of proactive. Anticipate what problems a patient can have and make sure they understand how to solve them. So things like inhalers. Will the patient have difficulty getting that at the pharmacy? What do they need to do if they have difficulty? What do they need to do if they have difficulty using the device? What does that look like? Recognize that there are some challenges that we already know patients might have and help the patient to navigate what they're supposed to do next. Improve your delivery model. You're not going to be able to do every single thing as the provider. You weren't designed to do that. The system is not designed for you to do that. So what can you delegate? How can you delegate effectively? How can you train and trust your new team members in these new roles and expanded capacity? Understand your quality data. Again, really hard if you don't understand what your quality data is going to look like when you get to submission time and it all is a surprise. And again, over and over and over, I feel like I've said this like a broken record, optimize your staff, optimize their skills and time and resources. Again, they are highly committed people who love and care about your patient population and have a great deal of respect for you. So give them the opportunity to really shine and to provide exceptional patient care. So I'm complete. I'm so excited to have been with you today, and I'm excited to answer some of your questions. So let's see if Charles added some. Here we go. Oh, okay, here we go. So Gary asks, is there any way to avoid copays? What is the regional adjustment? Let me start with avoiding copays. So in the program, you can create methodology for patients to avoid their copays depending on financial need, but it needs to be applied evenly across all of the patients. And so there's information about that in your PCF application documentation, and certainly in some of the practice documentation that you've received. The regional adjustment I actually addressed earlier. It's just an adjustment on your payments on based on where you are. So again, New York City will get a higher regional adjustment versus someone in Wyoming. How can an independent small practice decide if this is a preferred situation? So again, this is going to take some time looking at a spreadsheet, looking at what your past performance has been, getting a good understanding of what your billing cycles have looked like and what your patient population looks like. As far as audit scrutiny, not a lot of visibility from CMS with regard to audit scrutiny. I think if we think through what is CMS trying to accomplish, there may be some audit scrutiny, but a lot of it is going to be based on your production of metrics for the quality gateway, and then patient performance. How are patients doing? How is your practice doing relative to the regional and national cohort? Feel free to add more questions or follow-up questions. If I don't get to them, I'm more than happy to reach out after the webinar as well. Okay, Sally asks, how are services not related to primary care paid by Medicare when the practice is participating in PCF? So this is pretty straightforward. PCF has and CMMI has released the codes that are covered under that flat visit fee. Things outside of those flat visit fee codes are paid under traditional fee for service. So biopsies, in office kind of surgical things are some examples of things that will be paid under traditional fee for service. So, all right, let's see if there's more. Okay. When will CMS calculate the bonus potential? When will the practice see those bonus payments? So because of the public health emergency, then the bonus calculations won't happen until going into year 2. So you'll submit your quality information in February, and your bonus will be calculated and paid, at least based on the information I've read so far, in that Q2 of year 2 payment that includes your per beneficiary per month payment. So anticipate that is when you would get that bonus. So hopefully that answers your question. All right, this is a question related to CAPS. Are there any requirements for certification for vendors to provide the CAPS for the PC First, Primary Care First program to physicians and physician practices? So CMS has commented, CMMI has commented that they are vetting vendors at this point, and we will receive information about the vendors that have been approved for participation in the program, and we'll have more information, I anticipate, in the next 3 to 4 months about CAPS and what practices will need to do for that measure. Okay, other questions? I'm gonna go ahead and, Charles,
Right.
what
Yeah,
else
thank
are
you
you
so much,
seeing?
Roxanne, for that dive into this new exciting program. Now is the time for questions, so please do go ahead and submit those. While we're waiting for those to come in, we do have a quick poll for all of you who are still with us. We wanted to just understand, of the folks who have joined us today, who's been accepted and who's interested in the program. So I'm going to go ahead and launch that, and please do take a moment to let us know. And while that poll's happening, Roxanne, we have a question from Mary. Can you go over the Advanced Care Plan registry requirements?
Sure. So for submission of the Advanced Care Plan measure, it is a traditional MIPS measure, and it is a registry measure, meaning that information has to be submitted through a qualified registry. Mingle is a qualified registry. We're happy to help you. The Advanced Care Plan measure is not designed to force patients to have a advanced care plan, but really to invite them to start thinking about it. So certainly we can address that more specifically for your practice, but that information and certainly measure specifications are available as part of the MIPS program as well.
Okay, thank you, Mary, for that question. If you have a follow-up, please do feel free to put one in or be in touch. Thanks for everyone who's filled out the poll so far. Just give a few more seconds here. This is your opportunity to send questions in to Roxanne. If she can't answer them now, she will diligently get back to you. Another option for everyone is that if you are interested in understanding this program from the specifics of your organization, please do reach out, because we'd love to talk more specifically in the context of your location, your practice, your strengths, and understand what your thoughts are on this program and what the opportunities are and challenges are. We have a question here from Jay. What if we're not sure if we're eligible for the program? So that's a great question. We have some folks have been accepted and some folks who have an application coming up sometime soon. So Roxanne, can you dive into that a little
Right.
bit?
So the PCF program has two cohorts. The first cohort is to begin in January of 2021, and they would have applied back in January of 2020 and then were accepted late this summer. So those folks are already wrapping into cohort one. Cohort two, CMMI, or the Innovation Center, has identified specifically for CPC plus practices. So CPC plus practices will have the ability to transition into primary care first. Certainly, if you have questions about whether you'd be eligible, I'm happy to talk through that with you, but cohort one was kind of the general population. If you're interested in transitioning into advanced payment models, application was due last January. So this is just your next step in the journey, kind of making sure that you're ready for January 1, and then CPC plus practices will be cohort 2.
Coming right up here after the holidays in
Mm-hmm.
this challenging year. All right, so just one final call for questions. Beyond questions, I'm curious from the audience if anyone wants to comment of which component of the program they're feeling most confident about, or they're feeling like they might struggle with. Feel free to send that in as well in the chat. We'd love to understand kind of how your organization is viewing the program and the different components of getting that advanced delivery of primary care up and running or fine-tuned in your organization. And just a reminder that this webinar has been recorded, and we're going to be distributing the slides and recording later this week via email. Coming up in a couple weeks, we're going to have a session for those of you who are in CPC Plus. We're going to look at the two programs side by side a little bit. We do have a blog post out on our website that I put in the chat a few minutes ago, helping you see what's similar and what's different about the programs, but we'll have a session with Roxanne to kind of dive in a little bit and help you understand what you're getting into, what you're committing to, if you're interested in applying and rolling over from that CPC Plus participation. All right. So I think that's all we have for questions. So we want to go ahead and extend a big thank you to all of you for taking time out of your day for joining us today. We would love to hear from you and talk about your organization. So please do reach out on our website, minglehealth.com. And Roxanne, you'll get connected with Roxanne, and she's happy to help you think through the requirements and troubleshoot any issues. Mingle Health has been a qualified registry since 2012. So we are standing by and ready to be your qualified registry partner for primary care first. Not only will you get our registry services, but you'll also tap into Roxanne's expertise, staying up to date on all the program requirements, as well as sharing lessons learned across the participants that we are supporting. So please do, if you have been accepted, please do reach out because we'd love to be your qualified registry. With that, I want to say thank you to everyone and hope you have a great rest of your day, and stay tuned for the slides and recording. Thank you very much.